Hi, everyone. Thanks for joining us today. We have a lot to cover today, so we're going to start pretty soon. I'm just going to give folks another minute to sign on and get everyone situated. Hello, everyone. Thanks for joining us today for our 2021 enrollment webinar. My name is Dori Malazanov. I'm a manager on the Health Systems Integration team at NASTAD. Amy Killalay, Senior Director of Health Systems and Policy at NASTAD, is also with us today. And we're also joined by Molly Tasso and Mira Levinson from JSI. We will leave time for Q&A at the end of the webinar, so please feel free to submit questions for NASTAD and JSI using the GoToWebinar chat feature or question feature, and we'll address them towards the end of the session. The webinar will be recorded, and we'll circulate a recording and slide deck within a couple of days after today's presentation. I also forgot to add that my NASTAD colleague Meredith McCarthy is also here with us to help facilitate with Q&A. And just as a proactive apology, there's some construction happening next to my house. It seems to have quieted down. Hopefully it will not interrupt us, but I apologize if there is a little bit of noise, work from home struggles. Okay, so today we are going to cover the following topics. I'll talk about some coverage and policy updates affecting enrollment during COVID-19, followed by a discussion of how you all on the ground can prepare for the upcoming open enrollment period. And then my colleagues at JSI will talk about remote enrollment best practices and considerations. So with that, let's get started. First, some coverage and policy updates. As could be expected, the COVID-19 pandemic has affected enrollment in Medicaid and marketplace coverage. Medicaid enrollment has increased significantly in many states relative to pre-pandemic enrollment growth, and March 2020 saw the first nationwide Medicaid enrollment uptick in 3 years. Nationwide enrollment growth has grown by 3.2% from February before the pandemic to May, and adult enrollment increased by 4.3% during that time. Enrollment growth among adults has outpaced total Medicaid and CHIP enrollment growth on a monthly basis as well from March to April and from April to May. But note that May data here is still preliminary data and is subject to change. Medicaid enrollment growth has varied by states, with many states outpacing the national average and some states falling below. Oklahoma had the most enrollment growth from February to May at 8%. All but 3 states have seen overall enrollment growth since February. In general, we expect that job loss and loss of employer coverage will result in more people eligible for Medicaid, particularly in states that have adopted Medicaid expansion. But as the chart on the last slide showed, enrollment rates have varied widely from state to state. So why might Medicaid enrollment increase in a state? Some explanations for this include significant job losses caused by COVID-19, as well as the maintenance of effort provisions in the Families First Coronavirus Response Act that prohibit states from disenrolling Medicaid enrollees for the duration of the emergency. This means people who might have been disenrolled during this time for any reason have likely maintained coverage in many states, which is reflected in enrollment growth. Medicaid enrollment data tends to lag by a few months, so data available in the coming months may reflect even more growth as the pandemic wears on and people remain unemployed. In many states, however, Medicaid enrollment has not increased significantly or at all, and a couple states actually didn't see growth relative to pre-pandemic numbers until May. There are a few possible explanations for this. For example, the $600 weekly boost in unemployment benefits under the Federal CARES Act, which I'll talk about later, may have made COBRA coverage more accessible for families that experience job loss. Additionally, since this increased unemployment benefit counts towards marketplace income, it could have put families over the Medicaid cutoff, even if some or all workers in the household are unemployed. But keep in mind that this enhanced benefit expired on July 31st, and we still don't know whether or when Congress will authorize additional supplemental unemployment benefits. So it's possible that families who enrolled in COBRA or marketplace coverage will become eligible for Medicaid once their enhanced unemployment ends. August enrollment data isn't available yet, but we expect that termination of the enhanced unemployment benefits will likely correlate to a spike in Medicaid enrollment. Another possible explanation for why Medicaid enrollment may not have spiked everywhere is that many households may only have lost part of their income. For example, households with 2 wage earners where only one loses their job, and this might put families over the cutoff for Medicaid. Also, the Paycheck Protection Program, these are loans that small businesses can take out to mitigate financial impacts of COVID-19, enables businesses to keep employees on payroll even if the business is not currently operational. As a result, many workers may be eligible to keep their employer coverage or may maintain a household income that's too high for Medicaid. Similarly, workers who've been furloughed have likely also maintained their employer-sponsored coverage. And of course, consumer outreach and general public knowledge of Medicaid as an option also has an impact on how many people will enroll. Generally speaking, we expect high unemployment rates due to COVID-19 to correlate to higher Medicaid enrollment. Keep in mind, however, that unemployment rates are not consistent across the country. The national unemployment rate was around 10.2% in July, but state unemployment rates in July ranged from as low as 4.5% to as high as 16.1%. Medicaid coverage gains are similarly uneven across the country. Marketplace enrollment has also increased in many states. This highlights the important role that marketplaces play for millions of individuals and families experiencing job losses and income fluctuations, and fills the gap between employer-sponsored coverage, or ESI, and Medicaid. That is, it provides an affordable coverage option for households that lose employer coverage but have incomes too high for Medicaid. Marketplace enrollment could be increasing and likely will continue to increase for a few reasons. For example, 12 of the 13 states with state-based marketplaces had a special enrollment period, or SEP, for uninsured individuals to obtain coverage during COVID-19. This alone has resulted in thousands of new enrollments. Individuals may also be eligible for SEPs for other reasons. Loss of coverage is a common one these days, as many clients are losing their employer coverage. The CARES Act unemployment boost also may have made many families eligible for advanced premium tax credits, but many of these families may become eligible for Medicaid now that enhanced unemployment assistance has expired. However, in states without Medicaid expansion, many of these families may become ineligible for any type of affordable coverage once their enhanced unemployment ends. On July 25th, the U.S. Department of Health and Human Services extended the COVID-19 public health emergency for an additional 90 days. It now expires on October 23rd. This is important because a lot of critical health coverage access policies and consumer protections are tied to the public health emergency and will sunset when the emergency ends. This includes enhanced federal Medicaid funds for states that comply with certain maintenance of effort requirements. In other words, states that receive enhanced federal Medicaid funding during the pandemic may not disenroll consumers or impose new eligibility restrictions or premiums. States receiving enhanced funds must also cover COVID-19 treatment without cost sharing for Medicaid enrollees. The state option to provide COVID-19 Medicaid funded testing at no cost to uninsured residents who are not otherwise eligible for Medicaid is also in effect for the duration of the emergency. Currently, 19 states have implemented this option. Keep in mind that this coverage is limited only to testing for COVID-19 and does not include treatment. And also that immigration-related requirements for Medicaid eligibility are still in effect even under the state option. Also, states that have used mechanisms such as Section 1135 waivers, Section 1115 waivers, and state plan amendments to modify their Medicaid programs to expand access during COVID-19 are also typically scheduled to sunset when the emergency ends. Every state in the country has implemented at least one of these options, and most states have at least 2 of these options in place. For Medicare, policies tied to the emergency include relaxed telehealth restrictions and Section 1135 waivers. And for private insurance, this includes federal requirements to cover COVID-19 testing without cost sharing, including for out-of-network tests. Many states have also imposed requirements that go beyond federal law. such as requirements that insurance companies allow for off-formulary drug coverage, expand access to telehealth, provide premium grace periods, and relax network restrictions. As of early August, 37 states had at least one COVID-19 specific insurance policy in place. Insurance companies have also implemented similar policies expanding access, even in states where it's not required by law for them to do so. For more information about COVID-19 state, federal, and insurer level policies, you can find a recording and slide deck from our May webinar and our insurance coverage fact sheets on NASDAQ's website. Although COBRA may be available to many clients, it's often prohibitively expensive for a lot of families, especially if their employer is not contributing much. These families are eligible for an SEP to enroll in marketplace coverage within 60 days of losing their employer plan, even if COBRA is an available option. They do not have to choose COBRA. But keep in mind that once someone enrolls in COBRA, they won't be able to switch to a marketplace plan unless they do so within 60 days of losing their pre-COBRA coverage, or if their COBRA costs change because their employer has stopped contributing, or of course if they become eligible for some other special enrollment period. In other words, voluntarily dropping COBRA, for example, maybe a client wants to terminate it after their enhanced unemployment ends because it's now too expensive without that supplemental income, is not sufficient for an SEP. I'm sure this is familiar to many of you, but I just wanted to provide a brief refresher on special enrollment periods or SEPs. An SEP allows consumers to change plans or enroll in ACA compliant coverage either on or off marketplace outside of the annual open enrollment period. In order to be eligible for an SEP, the consumer must have experienced a qualifying life event. Here are some examples of qualifying life events, but it's not an exhaustive list. The first two are particularly relevant to the COVID-19 crisis since millions of people are expected to lose employer coverage or experience reductions in their income. If someone loses their employer coverage, they can apply for marketplace or off-marketplace coverage through an SEP. The SEP begins 60 days before they lose their coverage and ends 60 days after they lose their coverage. Consumers who miss this window generally won't be able to get ACA compliant coverage in 2020 unless they qualify for an SEP for a different reason. According to the Urban Institute, as many as 10 million people could enroll in individual market plans if they lose their employer coverage due to COVID-19. So SEPs are and will continue to be critical for a lot of people that need to get coverage right now. The second SEP I want to highlight is the change in income SEP, but I'll talk more about this on the next slide. There's also an SEP for individuals who lost coverage after January 1st, but missed the SEP deadline because they were impacted by a FEMA declared disaster, including but not limited to COVID-19. For example, they were sick with COVID-19 or caring for someone who was sick with COVID-19, and this hardship prevented them from taking advantage of their SEP. This is sometimes referred to in shorthand as the FEMA SEP. Now back to the change in income SEP I mentioned earlier. There's a new SEP that has not yet become available in healthcare.gov states, although some states with state-based marketplaces may have this available already. Nationwide implementation is expected eventually, but the date is still uncertain. The current rule, which is still in effect in healthcare.gov states and at least some state-based marketplace states, provides an SEP for marketplace enrollees who experience a change in income that makes them newly eligible or ineligible for advanced premium tax credits. Clients may switch plans, but are limited to choosing another plan within the same meta level as their current plan. However, keep in mind that if the income change makes the client newly eligible for cost-sharing reductions, which are discounts on deductibles and out-of-pocket costs that are only available in silver plans, they can switch to a silver plan if they aren't already enrolled in one. That rule hasn't changed. The current change in income SEP rule only applies to clients that already have marketplace coverage, though. So someone with off-marketplace coverage, for example, can't take advantage of this SEP unless they're in a state with a state-based marketplace that's chosen to implement the new rule. So under the new rule, people who had any kind of coverage without premium tax credits in the last 60 days, but experience a drop in income that makes them newly eligible for tax credits, can enroll in a marketplace plan. This will most likely primarily affect people who have off-marketplace coverage, since clients who still have access to affordable employer coverage are typically not eligible for premium tax credits, even if their income drops. If a client enrolled in off-marketplace coverage with income above 400% of the federal poverty level, and then experiences a drop in income that puts them below 400% and therefore within the range for tax credits, they can switch to a marketplace plan within 60 days of the income change. Even if someone already receives premium tax credits when their income is reduced and therefore can't get an SEP based on the income change, they can still update their marketplace application to see if they're eligible for a higher tax credit amount, enrollment in a silver plan with cost sharing reductions, or for Medicaid. In addition to all the usual SEPs, a number of states have created SEPs specifically to address uninsurance during COVID-19. Only states with state-run exchanges can implement this SEP, and all but Idaho have chosen to do so. Uninsured residents of the states listed here have or had an opportunity to apply for health coverage. They don't need to otherwise qualify for an SEP. Just being uninsured for any reason is enough to qualify. Each state had a different deadline, which I've listed here. Most of them have already expired, but a few states still have this SEP available. If the economic downturn caused by COVID-19 continues, it's possible states will reopen the special enrollment period, as some have already done. Washington, D.C. and New York are allowing enrollment in 2020 coverage for any reason through September 15th, and Maryland is extending this SEP to December 15th. Clients in Idaho and the 38 states that use the federal exchange website, healthcare.gov, don't have this COVID-19 SEP available to them, but they can still enroll in coverage if they qualify for an SEP for any other reason. Also, Idaho and healthcare.gov have relaxed documentation requirements for SEPs. So how can you help clients that have lost their coverage during COVID-19? First, it's important to screen clients for eligibility for other types of coverage. Medicaid enrollment is year-round, so any uninsured client who's eligible for Medicaid can enroll at any time. Marketplace coverage is available for clients who meet the criteria for an SEP, as I just discussed. Clients eligible for Medicare who have Part A but delayed Part B enrollment because they had employer coverage can also enroll in Part B. They won't have to pay late enrollment penalties. This is referred to as the Part B SEP. If a client with marketplace coverage experiences a drop in income, they should update their marketplace application. They may be newly eligible for APTCs or for a higher level of APTCs, or they may be newly eligible for cost sharing reductions, in which case they may be able to switch to a silver plan if they don't already have one. Also, clients with employer coverage may still be eligible for Medicaid premium assistance to help pay for their premiums. In our COVID-19 webinar in May, slides and a recording are available on our website. I discussed the Medicaid maintenance of effort requirements that allow states to receive enhanced federal Medicaid funding if they agree to certain conditions. If your state has agreed to take up the increased funding, that means they cannot terminate anyone from Medicaid after March 18th. So if a client was involuntarily terminated from Medicaid after March 18th, it's best to confirm whether your state has taken up this increased funding, and if so, help the client reinstate their Medicaid coverage as soon as possible. Even if your state is prohibited from disenrolling Medicaid members during COVID-19, it's still recommended that clients complete their redetermination paperwork on time. There are a couple reasons for this. First, this helps avoid disruptions in coverage after the COVID-19 emergency ends. And second, a client may be eligible for a different Medicaid eligibility group with more generous benefits. For example, Medicaid for older adults or people living with disabilities. So this is something that we haven't discussed in a webinar for quite some time, but I wanted to provide an update on short-term limited duration insurance. Many of you have heard me talk about this extensively in prior webinars because the Trump administration has expanded access to these plans by allowing insurers to sell them for up to 364 days. Before this change, these plans were only offered for a few months at a time. Given the high rates of unemployment, of coverage loss that people are experiencing right now, I just wanted to remind everyone that clients should be very careful to avoid enrolling in non-ACA compliant products like short-term limited duration insurance and healthcare sharing ministries. These products are not comprehensive ACA compliant coverage, but they're tempting because they're relatively cheap and they're deceptively marketed to confuse consumers into thinking they're ACA compliant. But these plans have significant shortcomings and are not sufficient to meet the needs of people with complex health conditions such as HIV. A recent investigation by the House Energy and Commerce Committee found that enrollment in short-term limited duration insurance is increasing, including among people with existing health needs. As we feared, these plans are engaging in practices such as post-claims underwriting to justify denying claims or canceling coverage altogether for people who are found to have a pre-existing condition or who had symptoms or risk factors at the time of enrollment. In other words, if the plan doesn't want to pay for something, they'll work very hard to find a reason why they don't have to. They also often discriminate against women by charging them higher premiums and denying women basic medical services. These plans also have very severe coverage limitations. In addition to pre-existing condition exclusions, they also often impose caps on how much they'll pay for certain services. And oftentimes they exclude coverage altogether for things like prescription drugs, which of course is very important for people living with HIV. These plans also engage in deceptive marketing, so clients don't always know what they're buying. They may think it's comprehensive coverage that will meet their needs, but it's not. People often don't realize that their coverage is insufficient for their needs until after their plan denies claims or cancels their coverage and leaves them with thousands in medical bills that they were never expecting and that they can't afford. Although 24 states have taken some action to regulate these plans, regulation is challenging because of deceptive marketing and lack of information about available plans. We expect marketing of these plans to only become more aggressive and widespread as more people lose coverage and face financial hardships during COVID-19, since the low premiums and deceptive marketing can make them seem appealing. Now I'm going to talk about unemployment benefits available during COVID-19, including additional benefits authorized by the Federal CARES Act. First, let's start with an overview of unemployment insurance or UI. Generally speaking, unemployment benefits are available to workers who have lost their job or experienced a reduction in income through no fault of their own. But the circumstances that render someone eligible or ineligible for benefits vary by state. Many people believe that losing only a portion of their income, being furloughed, quitting their job, or being fired for alleged misconduct are an automatic bar to receiving benefits, but this is not necessarily true. In general, it makes sense for a worker to apply for benefits if they lose their job or some of their income because they may be eligible even if they don't think they are. State laws vary significantly when it comes to the types of circumstances that render someone ineligible for benefits, and even if an employer contests a claim, the worker will have an opportunity for a hearing. Workers must also meet the wage and hour requirements for their state in order to receive unemployment benefits. They must have worked for a certain amount of time and earned a certain amount of money. Typically, a worker must also certify on a weekly basis that they're actively seeking work. But many states have waived this requirement during COVID-19. Under the Federal CARES Act, many workers who might not otherwise be eligible for unemployment can also access benefits in 2020. The amount of time someone can receive benefits also varies by state. In most states, workers can receive 26 weeks of unemployment benefits. The CARES Act increases the number of weeks that workers can receive benefits up to 39 weeks. But in some cases, workers may actually be eligible for up to 52 weeks of benefits. And finally, the amount of money a worker receives every week also varies by state and depends on how much they were making before they lost their job or part of their income. Note that although claimants usually must wait 7 days before receiving their first payment, many states have suspended this waiting period to ensure that workers receive their benefits as quickly as possible. The Federal CARES Act created unemployment programs to help workers who lose their jobs or experience reductions in income during COVID-19. First, the CARES Act provided an additional $600 per week in benefits to all claimants, regardless of the type of unemployment they receive. This $600 was in addition to the amount the person is already eligible for under their regular state UI program. This weekly boost in benefits expired on July 31st. As discussed earlier, it's still unclear whether or when Congress will authorize additional supplemental benefits, and even if they do, we expect the amount to be a lot less than $600 per week. Second, the CARES Act provides an additional 13 weeks of unemployment for workers who have exhausted their regular state UI benefits. These additional 13 weeks expire on December 31st. They do not carry over into 2021. After someone has exhausted their additional 13 weeks under the CARES Act, they may be eligible for extended benefits. This is not created by the CARES Act. This already existed before COVID-19, and it's a way for states to extend benefits in periods when there is very high unemployment. Extended benefits are currently available in most states. And finally, the CARES Act provides up to 39 weeks of unemployment for people who are not otherwise eligible for unemployment. For example, because they're self-employed, they lack sufficient work history, or they fail to meet any other state requirement for benefits. Also, people who are typically eligible for unemployment but who have already exhausted their benefits can apply for PUA to extend their benefits. In this case, the amount of additional weeks depends on how many weeks of benefits they've already received. These benefits, unlike the others I've discussed, are only available to workers who are unable to work or experience a reduction in income for a reason related to COVID-19. Some examples of valid reasons include a workplace being closed due to COVID-19, being unable to work because the worker or someone in their family has COVID-19, being unable to work because a child's daycare is closed due to COVID-19, and many others. PUA benefits also expire on December 31st and do not carry over into 2021. For more information about how these federal programs work, NASAD has recently added a short educational video about unemployment benefits during COVID-19 to our ONTAP Resources Center. Some of you may have heard about an executive order recently signed by President Trump that makes additional federal unemployment assistance referred to as a lost wages supplement available to some workers. The assistance isn't automatically available to everyone. Some states must individually seek approval to implement this lost wages payments, this payment program. As of August 25th, 32 states had received approval to implement this program. In these states, workers who are currently eligible for at least $100 per week may receive an additional $400 per week, $300 of which is federally funded, but only if their state kicks in another $100 per week or covers 25% of aggregate benefits provided to all workers that receive the supplement. It's a little bit confusing, but we are always working towards more clarity on understanding how this works. It's not clear right now how long these benefits are going to be available. They may be available until December 27th, unless Congress passes legislation before then authorizing federal unemployment benefits to replace or extend $600 weekly boost that expired on July 31st. However, there's a limit on how much money the federal government has available to pay for these claims, and experts estimate that the funds will actually run out by the end of September. So even if Congress doesn't pass legislation to authorize enhanced unemployment benefits, it seems unlikely that this program will actually be available through December 27th. So how do unemployment benefits affect eligibility for health coverage? Both regular unemployment benefits and the $600 weekly boost under the CARES Act are taxable and included in marketplace income. However, the $600 weekly boost was not included in Medicaid income. A worker's regular state UI amount will count towards their income for Medicaid eligibility purposes, though. It's still unclear how the lost wages supplement I discussed on the previous slide will impact eligibility. We're working on learning more about this, but for now, we suspect this will likely be treated the same as regular unemployment, that it will be taxable and included in both Medicaid and marketplace income. So how does this affect ADAP financial eligibility? This will vary by jurisdiction. The trend we're seeing is that states generally followed Medicaid policies and did not count the $600 per week boost as income for ADAP financial eligibility. Only a small handful of states definitively indicated that they plan to count this funding towards clients' ADAP income. If Congress extends enhanced unemployment, we expect states will continue to follow the same policies, but that will be up to each state to decide. As you know, a federal COVID-19 related legislation also included a one-time stimulus payment to help people get through these difficult times. Even though clients received this some time ago, we thought it was worth discussing because we think Congress may authorize additional stimulus payments in the future. The stimulus payment was a tax-free one-time payment of up to $1,200 for single filers and $2,400 for married filers. Most people have already received it. This payment was not included in clients' income when they applied for Medicaid or marketplace coverage. For ADAP purposes, the trend that we are seeing is that states generally did not count the one-time stimulus payments in ADAP financial eligibility determinations. The next round of payments, if authorized by Congress, would likely have a lower income cutoff than the first round and maybe for a different amount of money. We don't know for sure how these payments will affect eligibility for health coverage, but we think it's likely that the second round of payments will be subject to the same rules as the first round, assuming that a second round is authorized. So next, I'm going to talk about some considerations as you prepare for this unique upcoming open enrollment period. First, I want to start with some discussion about the 2021 plan landscape and what we can expect in terms of rates. Rates for 2021 plans have not yet been made publicly available in all states, but preliminary filings help illuminate some of what we might expect to see in 2021, my apologies. Based on Kaiser Family Foundation's review of preliminary rates in 11 states, rate increases vary widely. Most plans reviewed had rate increases of 2 to 6%, but some rate changes ranged from a 12% decrease to a nearly 32% increase. 37% of rate increases reviewed are attributable, at least in part, to COVID-19. COVID-19 will, of course, have an impact on 2021 rates. We expect final rates to become available in the near future. For now, issuers will continue monitoring the pandemic and may potentially revise proposed rates based on experience and available data. COVID-19 can put both upward and downward pressure on rates. Factors such as increased testing, widespread vaccination, and pent-up demand from delayed care may contribute to rate increases. On the other hand, many people have been avoiding and will continue to avoid care, especially if there's another surge of infections. Avoidance of care, such as preventive care and other types of services that people perceive as being non-urgent, is likely caused by fear of risk of infection in healthcare settings, as well as financial pressures during the pandemic. Many medical providers also chose to stop seeing patients for non-urgent care for some period of time earlier in the pandemic. I wanted to zoom in on one state, California, to illustrate how much uncertainty there's been around expected rate increases for next year, and also to highlight how state policies and other factors can contribute to rate changes. In March, California's Marketplace, Covered California, projected rate increases of up to 40% for 2021. Not surprisingly, insurance companies don't like uncertainty, so projections early in the pandemic were fairly pessimistic about 2021 rates. However, California's actual rates reflect only a 0.6% increase, which is actually the lowest increase since the ACA Marketplace's creation. There are a few reasons for this, potential reasons for this. First, measures such as social distancing and economic shutdown successfully flattened the curve, so hospitals and doctors were not as overwhelmed during the pandemic as they feared that they would be. Additionally, even though COVID-19 did increase issuer costs, this was offset by a decrease in elective procedures and non-urgent appointments for the reasons I described earlier about avoidance of healthcare settings. Although this avoidance of care during the pandemic can lead to higher costs in the future due to pent-up demand, California's market has actually proven stable enough to handle this influx of demand, and it has not impacted rates as severely as it could have. There are also some state policies that likely contributed to the low rate increases in California. First, the state's COVID-19 SEP allowed uninsured enrollees to sign up for coverage for any reason. As of the end of July, there were at least 231,000 new enrollments during this SEP. The SEP was then extended through August 31st. I don't have the data on new enrollments there, but at the very least, we know that by the end of July, there were at least 231,000 new enrollments. This is significant because a significant portion of these enrollees are likely people who have relatively low health needs, and they initially decided not to buy insurance because they didn't think it was necessary, and then they reconsidered once the COVID-19 pandemic hit. California also passed an individual mandate, which imposes a tax penalty on people who don't buy insurance, who don't have insurance. As you already likely know, the federal individual mandate was repealed, but some states, California included, passed laws to replace the federal mandate. California also provides additional marketplace financial assistance to supplement the assistance already provided through the marketplace, which of course increases enrollment because it makes coverage more affordable. California's income cutoff for advanced premium tax credits is 600% of the federal poverty level, which is much higher than the 400% cutoff that's required by federal law and in place in most states. California also provides enhanced assistance using state funds to enrollees between 200 and 400% of the federal poverty level who are already receiving federal subsidies, as well as to low-income immigrants who are ineligible for Medicaid due to the 5-year bar. Low-income immigrants in this category already receive fairly generous financial assistance through the marketplace, and California has supplemented this with state funds, bringing premiums down to nearly zero for many enrollees. Now I'd like to provide just a brief refresher of ADAP insurance purchasing cost effectiveness rules, and NASDAQ's plan assessment tool. So remember that the overall policy for cost effectiveness is that Ryan White grantees may assist clients with insurance premiums and cost sharing if two criteria are met. The insurance plan covers at least one drug in each class of core antiretroviral therapeutics from the HHS clinical guidelines, and two, the aggregate cost of paying for health insurance is cost effective relative to paying full cost for medications. This piece about aggregate costs is important to remember. It means that the average cost per insured client must be lower than the average cost per full pay client. So clients with lower insurance costs, for example, people with Medicare Part D or people with lower premium plans, can offset clients with more expensive coverage. RWHAP PCN 1801 consolidates several other PCNs related to private and public insurance purchasing using Ryan White funds. It also includes rules specific to different types of health insurance, Medicaid, Medicare, and private insurance. When determining cost effectiveness, it's important to consider the net costs, including discounts and rebates. This means you shouldn't rule out more expensive plans right away. Look at the net costs, including rebates, because the rebates may be enough to offset higher cost plans. NASDAQ's cost effectiveness tool, which many of you may already be familiar with, is going to be released closer to open enrollment for our next iteration of the tool. There will be some changes to account for new medications coming to the market, but the functionality will be the same as last year. If you have questions about the tool, you can reach out to Amy Killalay or Tim Horn at NASDAQ, or you can email me and I will put you in touch with them. Before I hand things off to my colleagues at JSI to talk about remote enrollment practices, I just wanted to go over some strategies to ensure a smooth open enrollment period this year and sum up some of the things that I've talked about. Of course, this open enrollment is going to be different from past open enrollments due to the ongoing COVID-19 pandemic. We've seen states implement policies to streamline enrollment and recertification, including extending deadlines, relaxing documentation requirements, allowing verbal or written self-attestation, conducting enrollment and recertification by phone or electronically, and accepting verbal client consents. Client meetings and assessments can also be modified to allow for social distancing, for example, by extending deadlines, talking to clients on the phone rather than in person, waiving client signature requirements, and using telehealth for routine visits and evaluations. We encourage states to continue strengthening these policies and processes to ensure smooth open enrollment, and my colleagues at JSI will talk about this more in the next portion of the presentation. States are also encouraged to continue assessing cost effectiveness of plans and rebate generation impact on program funding. And NASDAQ is here to support these efforts through technical assistance and our cost effectiveness tool that will be made available in the near future. And in light of these unusual times, we encourage you all to continue working even more closely with clients to assess eligibility for different coverage programs, particularly as clients lose coverage or face financial challenges during the COVID-19 pandemic, as well as to continue monitoring state and federal policies that affect coverage and access during the pandemic. NASDAQ has several COVID-19 resources on our website, as well as on our ONTAP Resource Center. I've included links in the next slide to support you in these efforts. We continue to monitor these policies as well and to keep you updated. And of course, we're available for technical assistance. Here's a list of resources from NASDAQ, HRSA, and the ACE-TA Center that may be helpful to you before, during, and after open enrollment. We'll circulate these slides in the next couple of days so you can access these links easily. Don't worry about saving them now. So this concludes the first portion of the presentation. I'll be available for questions at the end of the webinar. Please utilize the chat box feature or question box to submit questions. And with that, I'll hand it off to JSI to talk about remote enrollment practices for the upcoming open enrollment period.
Thanks, Dory. Mira here. Can you hear me?
Yes, we can hear you.
Okay, great. So Molly and I are going to be presenting on a few updates and considerations as we all prepare for Marketplace open enrollment. Next slide, please. I'm thinking many of you are already familiar with JSI's ACE-TA Center, but for those that aren't, ACE stands for the Access, Care, and Engagement TA Center, and we are a HRSA-HAB supported cooperative agreement, and we've been collaborating with NASDAQ since we started up this project in 2013. Next slide, please. Thanks. So our focus is on building the capacity of the Ryan White community to navigate the changing healthcare landscape and to help people with HIV to access and use health coverage to improve health outcomes. And in the last year or so, we've expanded our focus to cover Medicare eligibility and enrollment, in addition to the work we've been doing around Marketplace and Medicare coverage. So we develop and share best practices and supporting resources and provide TA and training through national and localized activities. Next slide, please. We work with a variety of audiences, program staff, people with HIV, program managers and administrators, and also people who help enroll Ryan White clients like navigators and certified application counselors. And we would encourage you to share information about the ACE-TA Center with your subrecipients and other enrollment partners, as well as with your newer program staff. And in fact, we have a webinar coming up later this month that is specifically designed for new program staff to help them get oriented to our health coverage resources. People can subscribe to our email list and register for our emails to learn about upcoming webinars and other events at targethiv.org/ACE. So next slide, please. These days, there's a lot of interest in learning about how to conduct enrollment remotely. In fact, a lot of organizations have already been doing this for quite some time around special enrollment periods. So I'm just going to share a few thoughts on how some organizations are thinking about remote enrollment and how your organizations can think similarly about how to engage their clients remotely. Next slide, please. So certified application counselors or CACs and navigators do not need to be in person to provide enrollment assistance. And consent can be provided in a number of ways, by the client themselves or by an authorized individual, by phone, in writing, or both. And there's a useful resource from CMS from 2017 on how to obtain authorization. And I'll try to chat that link out in a moment while Molly's presenting. So that CMS resource is called How to Obtain a Consumer's Authorization Before Gaining Access to Personally Identifiable Information. But enrollment assisters need to be trained on how to safeguard consumer privacy, both in their physical workspace and online, and how to sign and send documents securely. So let's start with privacy and go to the next slide, please. So a few things to keep in mind for safeguarding consumer privacy. While many organizations are already doing this for staff that are working on site, it's really worth thinking all this through in the context of people working remotely, as well as specifically in the context of enrollment. So let's think first about online communication. Starting with making sure that enrollment staff are adhering to any organizational policies, as well as HIPAA requirements when exchanging personal health information. So that's sort of a training point for you all to keep in mind. Staff should also be required to use a strong password to log into their physical computers, not just into email. And another key training point for staff is that they should never, ever use email to share protected health information or PHI unless they're using secure email. And secure email has particular features like end-to-end encryption, two-factor authentication, and an SSL certificate. Organizations can also train staff to encrypt and password protect documents for added security, and never to send passwords along with login information. So again, that would be sort of in addition to making sure that you have secure methods for transmission. And for remote staff in particular, we encourage them to work with organizational IT resources to make sure that their wireless network is secure, and otherwise it's best to avoid using it. Organizations can also consider installing a firewall. And managing physical space can also be complicated. So people need to think about how to work in a private space to protect the caller's personal information. And staff need to not share a computer with anyone that shouldn't have access, such as other household members. And I know that can be especially complicated. People should also make sure that others in the household or in the work area can't see any paper or electronic client information. And paper can be especially hard to keep private, especially when working remotely. So people should store printed materials containing PHI carefully and securely, and limit the amount of paper with PHI. Next slide, please. Organizations should also have their own requirements in place in terms of acceptable options around signatures and sending documents. In general, people can send documents in need of a signature by using secure email or fax. And eFax app, Fax Pro, and others are free online fax programs. And there are also a variety of options for obtaining signatures electronically, like DocuSign, Adobe Fill and Sign Now. And again, organizations really just need to look through those options and figure out what's going to be acceptable from their organizational perspective. And next slide, please. Before I hand it over to Molly, here are just a few tips for ensuring privacy when talking on the phone. And Dory will share this slide around so people can look through it in more detail. But in general, it's best if staff don't have to share their personal phone numbers. So set up call forwarding, consider using features like *67 to block their phone number or change their information otherwise so that it stays private. Because clients may also be remote, it's important to also make sure that staff are talking with the right person. So they need to be trained to make sure that they're speaking with someone who's authorized to speak on the client's behalf. And organizations, if they're not doing so already, should consider subscribing to a language line or an interpreter line to help clients in other languages. And we also encourage using a headset instead of a speakerphone for better privacy. So that's all for me. I'm going to hand it over to Molly Tasso to share some key messages and resources to help staff prepare for open enrollment in other ways.
Great, thanks so much, Mira. So I'm just going to discuss, again, some enrollment best practices that can be applied, whether working remotely or in person, both during the upcoming open enrollment period, but also throughout, really throughout the years we do enroll people through SCPs and for other reasons. Next slide, please. So first, we really encourage any enrollment assistant or case manager, and I'm just going to use case manager sort of as the default term here moving forward, but we encourage these folks to conduct what we call an account tune-up with clients who will be re-enrolling into coverage this fall. And this is an appointment that really is just to discuss how to prepare folks for a speedy and successful enrollment. And as a high-level overview, an account tune-up is really just a meeting that a person will have with a client before open enrollment, and during that they will discuss there's sort of 4 general steps involved. So they will check paperwork, including accounts and payments, so like marketplace accounts, and making sure that all of their payments with their current insurance plan are up to date. They will review finances, so to discuss what financial eligibility they might have for different financial assistance through the marketplace or their ADAP program. They'll confirm enrollment into Ryan White programs such as the ADAP program, and also do some client education to prepare for the actual enrollment appointment that will take place down the road. Next slide, please. So after that account tune-up, of course, the case manager will then schedule a time to actually meet with the client, either in person or remotely, and actually conduct the enrollment. And so when setting up this meeting, we encourage people to use that time to speak with the clients about expectations for that appointment, and making clear that it may not necessarily result in an enrollment. For example, you may begin the screening process and realize that they might be eligible for a different type of coverage, such as Medicaid or employer-sponsored insurance. But that sort of setting the expectations from the start really help make sure that everyone is on the same page about how to prepare and what to expect. Also making sure the case manager should be making sure that the client knows what to bring to the enrollment appointment. And then of course, providing the client with all the logistical information ahead of time. So if you're meeting remotely, making sure that the case manager is very clear how to be reached, or if they're meeting via Zoom or GoToMeeting, making sure that they have the link to join. And then if you are meeting in person, make sure, of course, that they have all of the sort of logistical information, such as mask requirements or how to enter the building, if they need to come alone or if they can bring another person, making sure all that information is provided ahead of time so that the enrollment is really smooth and straightforward. And then finally, just using the time before and during the open enrollment period to communicate key messages to clients. Just a few here on the slide, just really hammering home the importance of health coverage, reminding folks that the Ryan White program is not insurance. Being sure to review plans to check for preferred HIV medications and providers, and of course, as Dory mentioned earlier, just reminding folks that a cheaper plan isn't always a better plan. And then the next 3 slides, I'm just gonna sort of fly through because I do wanna provide time for Q&A, but we do have, the ACTA Center does have some great tools to support programs and case managers through open enrollment. So on the left, you see an eligibility decision tree that helps case managers and clients sort of move through a series of questions to determine what health coverage they might be eligible for. So whether that's employer-sponsored insurance or marketplace coverage or Medicaid. And then on the right is the account tune-ups resource that walks through a little more in depth the four steps involved in an account tune-up that I referenced earlier. On the next slide are a couple tools that we have for consumers. So these are designed specifically to share with Ryan White clients. The tool on the left is called Get Covered for a Healthy Life, and it's designed to help folks who haven't enrolled in health insurance before learn about the benefits and answer some really common questions like, why do I need health insurance? How do I pay for health insurance? Things like that. And then on the right is our resource called Making the Most of Your Coverage, which covers then, so you've enrolled into health coverage. Then there are questions such as, where do you go for care? What's the difference between in-network, out-of-network, differences between a primary care provider, specialty care, et cetera. And so these are available to be printed and handed directly to clients. And of course, like all of our consumer-facing tools, these are also available in Spanish. And then on this last slide is a screenshot of our e-learning module that it's preparing for open enrollment e-learning package. And it's a sort of e-learning module that folks can move through to really learn in depth everything they need to know for the upcoming open enrollment period, including preparing for and conducting account tune-ups. So Dory, I'm going to work with Dory to see how we can send out links to those so you can actually access them. But on the last slide, we just want to say thank you for joining us and having us today, NASDAD. You can sign up for our mailing list and get our webinar announcements and download our tools and resources at the website. Next slide, please. targethiv.org/ACE. And if you have any questions, please do contact us at the email address there. So I'll hand it back to Dory for Q&A.
Thanks so much, Molly. Here's contact information for JSI with any questions that come up after the webinar. I neglected to include my own contact information. I apologize, so I just sent it out in the chat box. Please refer to the second one because the first one I mistyped. I conflated my personal and my work email. It's been a long Tuesday. So my contact information is in the chat box. And let's give folks a moment here to see if there are any questions that come in. I think I just saw someone with a hand raised, or was that just a mistake? Okay. So I don't actually see any questions here right now. It seems like we did a great job. Everyone's an expert. So there's still some time here to submit questions if anyone has any. Please feel free to do that. Okay, great. We see. So we have a question here about the FEMA SEP. Is this FEMA SEP for anyone who lost coverage since January 1st, or does it apply only for people who lost coverage with an SEP? I think what this question is asking is, to whom does this FEMA SEP apply? So the FEMA SEP is for anyone who qualified for a special enrollment period more than 60 days ago, meaning that they missed the deadline. And the reason that they missed the deadline is because of a FEMA declared emergency, which includes COVID-19. So if someone qualified for special enrollment more than 60 days ago but missed the deadline, they can be eligible for another special enrollment period if a disaster was the reason for this, that they missed the deadline. Also, if the SEP that the person missed is due to a loss of coverage, and they lost their coverage more than 60 days ago, but after January 1st, they can apply online through healthcare.gov to see if they qualify for the SEP. If they missed any other type of special enrollment period other than the loss of coverage SEP, then they must contact the Marketplace call center to see if they're eligible. But generally speaking, the FEMA SEP is for anyone who had qualified for special enrollment period more than 60 days ago, but missed it because of a FEMA declared disaster. Great, there's another, let's see, I think we have another question here. Sorry, just bear with me while I look at this. Meredith, do you see, I feel like my view is a little small here. Sorry, hold on. Here, I can pop it up. Perfect.
My view is also kind of small, but I don't see any other additional questions.
So I'm not sure. So I'm not sure that I'm understanding this question on the FEMA SEP. So if there's any additional information that anyone, any additional questions anyone has about the FEMA SEP, you can feel free to send me an email and we can follow up to discuss that. But that's basically an overview of how the FEMA SEP works. And COVID-19 is a FEMA declared disaster, and therefore folks who lost coverage and missed the deadline because of COVID-19 related reasons may be eligible.
Dory, this is Molly. Can I just add one thing to that? Because we at JSI have been sort of researching and trying to wrap our heads around this as well. But one helpful thing for me was a recognition that this SEP has actually been around for a number of years, and it's often used to provide relief for those impacted by a natural disaster, such as a tornado or a hurricane. So it's been more sort of regional in the past. But this is the first time, at least in my lifetime, I believe that there's been like a national, well, I don't know my lifetime, but since the ACA, that there's been a national FEMA declared emergency. So it used to be like it just impacted people in certain counties who were impacted by a tornado. Now it's impacting literally everyone in the country. So it just really expands the access. But this SEP has been around for a number of years.
Great, thanks, Molly. Okay, got it. So the clarification that was requested before was about whether the person needed to have qualified for an SEP before COVID-19. It would have been either if they lost coverage since January 1st, they might be eligible for the SEP. Alternatively, if they missed an SEP during a FEMA declared emergency, which would have started after January 1st, and they might also be eligible. For the loss of coverage specifically, folks who missed the loss of coverage SEP can be eligible if they lost that coverage anytime after January 1st. Okay, well, it seems like we don't have any other questions. As I said before, please feel free to reach out to myself. My email address is in the chat box, or to JSI. Their contact information is on the screen with any additional questions that may come up. And please look out for slides and recording in the coming days. Thank you so much.